Hey, welcome back, everybody. It's time once again for another episode of Living Hope. The one show, the only show that talks about the real people and what they're really going through with this deadly disease, pancreatic cancer. With the one woman, well, she's kind of met more of these people than most, because she's one of them. Let's bring her in. Roberta, Luke, wow.
Thank you. It's great to be back. Good to see everybody. Well, at least the three of us, right?
The three of us here.
Can see the three of us. I see everybody. Sorry about that.
It's all of us here. The big studio audience. Well, listen, we should play the applause sound here for the hundreds of people.
Oh, that would be fun. That would be fun, right?
So who'd you bring with you this week here?
Today I have Dr. Sandra Sachs. She is a triple board certified physician in anesthesiology, palliative medicine, and pain medicine.
One wasn't enough. She had to do it 3 times there?
Hey, that's quite a woman, and she's young, so, that's great. She is a cancer pain specialist at UCLA and is committed to delivering compassionate and quality palliative care to patients and their families. Thank you for coming down today. I'm not sure how far of a drive you had, but I really do appreciate you coming in and talking to us today, so thank you.
Thank you so much for having me.
We've had recently a guest who we've talked about palliative care. She was a nurse practitioner and became a pancreatic cancer patient as well. So we were able to speak with her and kind of get her perspective, first as being the nurse and then as being the patient using palliative care. So as a doctor, what is your perception or knowledge and stuff with palliative care? Sorry.
Yeah, that's a great question. And, I tuned into the podcast last week, and what Lisa shared was amazing. I think that there's a big misconception about what palliative care is. Oftentimes I hear patients saying, well, should I go on palliative care now that my disease has progressed? Or is palliative care now for me only after, my options are limited? And I think that in those situations, patients and also other physicians should be educated on exactly what palliative care is. I think oftentimes people think that palliative care is the same as hospice, but palliative care is a big umbrella that encompasses so much, with hospice actually being a small part of it towards the end. But in general, palliative care is for anyone who has a serious disease. So at the time of diagnosis with pancreatic cancer, people can use palliative care as a resource. And there are multiple people on a palliative care team. So doctors, nurses, social workers, chaplains, there's even palliative care trained pharmacists, nutritionists. So all of those people can be part of your team, and they can be involved as much or as little. So if you don't have many symptoms, if you don't have a lot of distress, they sort of take a step back, but they're part of your care team early on once you're diagnosed. And then if things, start to get a little bit more difficult, then they step in a little bit more and you see them a little bit more often.
You did bring up the word hospice, so maybe if you could just explain the difference between the two, please.
Yeah, absolutely. So hospice is for patients who have a limited prognosis. So typically for patients who have 6 months or less, if the disease were to progress naturally without any intervention. So if oftentimes people with, really diffuse metastatic disease and advanced disease, and if they decide not to go on any cancer-directed treatment, you need, doctors may say, you probably have less than 6 months. I wouldn't be surprised if this patient died within 6 months. Then that patient would be eligible for hospice services. And in that case, patients often, you don't typically get chemo treatments or cancer-directed treatments while you're on hospice. Whereas with palliative care, that sort of team-based approach can be used concurrently with your cancer treatments. So they work alongside your oncologist, and you're getting cancer-directed treatment at the same time that you're getting palliative care.
So hospice care would be mostly just to keep the person comfortable until their time came?
Yeah. In both cases, you're talking about quality of life, and that quality of life, can mean different things throughout the different times of your treatment and your disease. But in hospice specifically, you're really talking about comfort care in the last months days to months of a patient's life.
I think Paul has a question for you.
I went
Sure.
through this with my late aunt, my mom, my dad, so I'm a little familiar with all this. My mother was a hospice worker later in her life, and then ended up benefiting from that as she died. The one thing I don't think people understand is this middle stage, because hospice is somebody has to say you probably have 6 months or less to live, and then that qualifies you. And when it does, my understanding, at least in our case, that means you stop seeing the doctor, you stop getting the treatment. So all of that care stops. The doctor doesn't see you. I don't know if he won't see you, but they just, if once you move into hospice, a new team takes over, and it's really there to make you as comfortable as possible, spiritually, mentally, physically, everything that they can do. And you do qualify for other things. You can get certain, I don't know, wheelchairs and other devices at home and other sorts of things. Other sorts of programs kick in to do things, but they kick you out of traditional care. You stop seeing your doctor, stop going to the hospital, stop doing other things, because the assumption is you're not going to live much longer here. But you can go in and out of it. You can say, oh, suddenly I'm doing better. And you can't say, oh, I gave up. My aunt was afraid to go into it because she thought, once I do, I'm dead. Well, and I'm not sure I'm ready to declare that I'm ready to die. I still want to keep fighting it. I still want to keep going. So she didn't go into hospice because they kept saying, once you do, you don't get to come in and take your shots and all the other things that she did. So talk about that. You can go in and out of this thing too, depending on, it's an elective.
Yeah. So hospice is a choice by the patient and the family, and you can enroll in hospice and also come out of hospice whenever you want to. And you can also change hospice companies if you're
Right.
unhappy with the hospice agency that you're with. So we do have patients occasionally who are, their oncologist says, you're too weak to get another round of chemo. We really just want you to regain your strength right now. And we do occasionally have patients that, there's no options left for cancer treatment. They end up deciding to enroll in hospice. They stay at home. They're surrounded by their loved ones. They actually end up getting stronger. They're not experiencing the side effects of chemo treatments. They're regaining strength, doing the things that they love at home. And they're like, I don't really need hospice services anymore. I think I want to go back and get my oncologist's opinion whether or not I can resume treatment at this time. So patients can definitely move in and out of
What
hospice.
are the benefits to hospice, and why would anybody go into it? Because you had John from the hospice, OC Hospice Care in here, and he was talking a little bit about that. What do you get when you go into hospice?
I think
We talk about what you don't get anywhere. You don't get treatment. You don't get chemo. What do you get when you go there?
you get like a multidisciplinary team. You have nurses, hospice care workers that come and check on you. I think it's important to know that it's not 24-hour care. So you don't have someone who's going to be in your home all the time. And hospice can take place in multiple different places. Most oftentimes it's done at the patient's home. But there are also facilities and nursing homes that can offer hospice or have agreements with certain hospice agencies.
But you do get access to somebody more than you do when you're outside hospice. You
Yeah.
get more, somebody you can call them in the middle of the night or different places and
Yeah.
different things and stuff.
Yeah, absolutely. So you have people that you can call on, and for every single patient, although you may not see the doctor all the time, there is a physician that oversees all the care. You may
Right.
interact more with the nurses or the hospice care aides that come in, or in a couple hospices that I've worked in, they even had music therapy. So they would have a music therapist that would come, and a chaplain, and a social worker that comes in to check on you. And it really gives the family support as well. So,
You hit the two nails on the head. One is we're grieving. We don't know what to do. And they start to walk you through, well, here's options for cremation. Here's choices. Here's things you can do. Here's handle your grief, how to handle their affair. I mean, you get a lot of support, and people ask questions. Otherwise, the doctor's sharing. Like Mark's, for instance, was the doctor said, I don't know. I don't know what to do. That's not up to me. I'm here to solve this problem. I'm not here to make you.
yeah, there's
Right.
a lot of bereavement support that's offered to the families with hospice. Everybody is trained to know the different resources that are out there because, again, most people, we don't know what to do. We're not trained to sort of make those kind of decisions, when our loved ones
So I'll ask one last question, and then I'll shut up and let Roberta jump back in. So the other question, so that's what hospice is, end-of-life care. And there's a lot to that. You give up some things, you give up the fight maybe, but you settle in for the final journey here. And a lot of people to support you. And up to the point when my aunt died, there were people there surrounding her and holding her hand and comforting her and everything here. Things that you wouldn't get. The doctor didn't show up to hold her hand and guide her, walk with her that last steps here. However, there's this thing called palliative. And I don't know. I'm not even sure I know what palliative is. It's in between. You still get treatment. You still get help, but it's like a support network. You need more, but it's not hospice.
Mm-hmm. So it is.
It's a transition.
Mm-hmm. It's a modality of care that is for patients with serious diseases. So we use the term serious. We don't use advanced. Really, it doesn't encompass just cancer patients, but people with heart failure, people with kidney disease, people who have had strokes, people with advanced dementia. Anybody who has a serious medical disease can qualify for palliative care. And that palliative care can be delivered as an outpatient. It can be also delivered as an inpatient. So when a patient is admitted in the hospital, their primary teams, the medical teams, can consult palliative care, and they can come in and sort of introduce their role. And then oftentimes, if you're at a big institution that has outpatient palliative care resources, they can then follow up with palliative care as an outpatient, and they can provide family support as well as symptom management for the patients, whether it's pain, nausea, delirium, appetite loss, all sorts of different types of symptoms. The palliative care team can all work together to help the patient and the family out.
This is a question, maybe you might not know the answer, but I'm just curious because I was diagnosed in 2002, and palliative care was never even mentioned. Hospice was brought in, obviously, but palliative care was never even mentioned. Is this a new thing, or when did it start, or how long has it been around, and why are we not hearing more about it? Why are doctors not saying, this is something you should be benefiting from?
Yeah, palliative care has been around for a long time. I think that it comes down to resources that health systems and certain hospitals have. Palliative care as a field is growing, and I know, at UCLA, our palliative care division has grown immensely in the last, 5 to 10 years. And it's gaining a lot of, more people are learning about it, patients are asking for it, so the demand is there. And so, I think that the urge to expand the resources are there, but it's been around for a long time. It's not a new concept. And I think there's a lot of misconception too within the medical field. Sometimes doctors themselves don't really have a clear idea of what the difference between palliative care and hospice is. And some doctors may not be able to explain what palliative care is to patients correctly, and maybe patients then get the misconception that palliative care means giving up, or the same as hospice. So I think the more that we can educate everybody, the better it is, and because it's a wonderful resource for anybody with a serious disease to have on their team.
Yeah, I think, like I said, I probably could still benefit. I don't know, but it sounds like it's something great. Like you say, you have all these people come in, and again. So how would somebody know, okay, I need palliative care, or who would even suggest it, or how would it even start?
Typically, it would come from the oncologist making a referral, if we're talking specifically about cancer patients. But that being said, I think the more that patients are educated, if a patient is diagnosed with stage 4 disease, metastatic disease, I think that in itself is already a great reason for them to seek palliative care. And if the oncologist doesn't bring it up, I would ask the patients to bring it up with their oncologist, or ask, some of their other doctors to see what sort of options there are within their health system for palliative care resources.
And how does the patient, though, find out about palliative care? Sorry if I'm putting you on the spot.
It's a great question.
You got to have the secret handshake. You got to know where it is.
I think it ultimately comes down to their primary provider. So when they're diagnosed with cancer, often that's the cancer team, and asking them just, is palliative care available? What do you think about palliative care for me? And, it becomes a little bit challenging if their oncologist or their primary medical team may be one of those who have those misconceptions of what palliative care is, and they may not necessarily want to
don't
refer
have it
them.
in their system.
Yeah, or if it doesn't exist within their health system, it's hard.
Would you find that mostly in the larger areas, or
Yeah, in bigger health systems, bigger like cities, you would definitely find palliative care in big academic centers, all cancer institutions.
So I looked at the term. There's a million sites out, but this one kind of says all. Palliative care is a resource for anyone living with a serious illness, in addition to improving quality of life and helping with symptoms, help you I guess deal with this better. It also helps patients understand choices. So you get additional services and some additional information. It sounds like.
Yeah, I had a friend that was on palliative care, and she, like, her minister came, or a minister came in once a week. She had a volunteer come in a couple times a week to help her with letter writing or whatever she needed, and then another nurse to administer medication. Another one helped her with showers. So are these typically what happens in palliative care?
The kinds of things you get.
Yeah, I mean, there are all sorts of different team members on a palliative care team. So aside from the medical, nursing, physician, that kind of symptom management, you also do get the chaplains, the spiritual support. I was going to say a lot of bigger hospice agencies now often have a palliative care arm. So there are outpatient palliative care options, often that aren't necessarily connected with the immediate hospital. So like at UCLA, we have a palliative care division, but I know that there are neighboring hospice agencies that also offer outpatient palliative care, where the palliative care nurse will see the patient at home, and offer support, check vitals, offer some suggestions for symptom management. So they're already sort of the patients are introduced to this agency, and if the time ever came where their disease progressed and there's limited options for treatment, and if they decided to enroll in hospice, they're already within the system of that agency.
And as far as palliative care, I mean, is it free? Is it
Yeah.
covered?
Who pays for this?
Yeah, does your insurance cover it, or how does that work?
It's typically part of your insurance covers it. I think the big thing with hospice, why all of the medical treatments for the disease are no longer an option, is because usually with Medicare, hospice is reimbursed by Medicare, and so it all comes down to insurance. But with palliative care, it's also covered by insurance, and you can still get treatment with your oncologist and all of your other medical teams. So you can still see, your cardiologist. If you have hypertension, you can still see your primary care doctor. You can see everybody that you need to.
So once you're diagnosed, given a determination, you probably have 6 months or less to live, in somebody's opinion, your doctor's opinion. Then hospice, once that's reported to Medicare, they're trying to conserve costs. Why would I keep giving you chemo if you're going to die here? Why, if this isn't going to work or help or anything anymore? So at that point, they don't want to reimburse you for additional expenses to fight it, just to make you comfortable and to prepare you in this last step here, kind of.
Yeah.
I mean, I'm trying to be
I don't know
cold,
really what they think and what the thought process is.
But palliative is a support team on top of what you're doing. So you don't stop doing anything. This is an addition to.
Correct.
And you would help, like, with pain management, if problems eating, those type of situations.
And a big part of what we do as palliative care providers is communication. So we know that being diagnosed with a serious illness is difficult for the patient, for the family, for loved ones. Having difficult conversations can be awkward. So we help mediate some of those conversations. We have goals of care conversations. We really try to get to know the person, of who they are, what's important to them, how they like to receive information about their disease. And, some people want to know all the little details. Some people only want to know the big picture. And then, talking about end of life, end of life options and what they want if things progress, or if an emergency comes up, do they want to be on a ventilator? Do they want chest compressions? Having those difficult conversations before there's an emergency that happens to take that weight of those heavy decision making from the family members and loved ones when something emergent comes up.
Can I ask one more question? I keep saying
Of
I'm not going to
course.
ask anymore. I know this is Roberta's show here, but I was so deeply immersed in this thing and so amazed that we didn't know much about this. We didn't understand it. I don't know. We took advantage of it to its full degree. And so I think a lot of people, like Roberta said, don't know about it, don't know what to do, don't know what you get, don't know what you don't get, and all these things. Palliative is the most fascinating one because nobody talks about that one. I never hear about it. Why did you go into palliative care? Because you're not curing anybody. A doctor's there to cure, to fix. You're gone. You don't see me anymore. Goodbye.
Yeah.
I did my job. Hooray.
I love to share my own story. You know, I trained in anesthesiology. I thought I was going to be an ICU doctor. I spent a lot of time in the ICU unit, and I think the most impactful experiences I've had was really getting to know the family members of a patient and learning who that person is that we were treating, what they like to do, what they enjoyed doing, and who they were as a person. And you know, oftentimes in the ICU, everyone is so busy. We're treating numbers, we're chasing after lab values, we're looking at imaging, but we don't spend enough time learning who they are as a person. I feel like palliative care really gets to the bottom of, you know, bringing back the humanity of medicine, and getting to know the patient as a person, their loved ones, who their support network is, and treating them as they want to be treated. You know, people all...
That doesn't sound like medicine to me today. I get to know them, treat the way you want to be treated, all this stuff here. Is that the way your experience was, Roberta? Is that the way medicine functions here today?
I think we lose that, you know, as doctors, we want to help everybody, but we don't want to put our own ideas we don't want to treat people how we want to be treated. We want to treat them how they want to be treated. And I think palliative care really puts gives that back to the patients, to give them the power of, you know.
And I think that's the big word you said, power or control, because in this disease, and I can't speak on others, but with pancreatic cancer, once you get that diagnosis, you feel like you've lost all control and all power.
Yeah.
So to be able to give that back to the patient, I think is just something that can really help them continue on with the fight until they're ready to say that enough is enough. As far as palliative care, so the family, they benefit as well, or is it mostly just the patient that's going to benefit?
You know, there are definitely resources for the family, just support for the family. I think that being caregivers while a patient is undergoing cancer treatments and going through all of this is very burdensome. And it just, in my palliative care is just a resource where families can really sit down, talk about the stressors that they're facing, and you know, a palliative care provider can really be that active listener to help them, you know.
Is it one size fits all? Everybody does the same program, so if I go to one hospital, it's the same as another hospital? Or do some really give you Cadillac care, as we used to call it, premium product, and some of them do just bare bones?
I think it ultimately depends on the provider and the team that you have. I'm not sure that you can really say, you know, a certain hospital or an agency is going to give you better care than another. I think that the people who go into palliative care are self-selected, usually pretty compassionate people who want to help. And so,
They're all there for the right reason.
Yeah, exactly.
Yeah, I think they would have to be, because they know, for one, the next step would be hospice, and you have to have that caring, that want.
Yeah.
So I think it takes a very special person that we've talked about to be into, you know, a hospice care person, as well as the palliative care.
We're down to our last few minutes. I got so many questions. I could just keep doing this, and I know Roberta's giving me this look like, hey, come on, I got a million questions here too. Can you change I'll try and make this the last one. Because you said in hospice, and when John was here from OC Hospice, once you go into hospice, once you qualify, you can pick whatever agency you want. And if you don't like them, you can go pick another one. They're being reimbursed by Medicare. And so you the patient, get to pick whoever you want. It's not just whoever your healthcare plan is with. Same thing true in palliative, or am I stuck with, if I'm in XYZ network, I got to use their palliative care?
I think it's a little bit more limited in that sense because there's not as many agencies out there as there are hospice agencies. In general, if you're receiving your cancer care, like, at UCLA or
Right.
UC Irvine, there may be a palliative care team that your oncologist works with that they would recommend that be part of your team. So it's often, I would say that the oncology team has a big say in where you get your palliative care.
And does the palliative care team communicate back with is there communication going on between them and the
Yeah,
doctors?
absolutely. I know, like, for me, I always make sure to touch base with the oncology team to let them know how the visit went and if there are any things that came up that I feel like they need to bring up with the patient in their next visit. So it's all very closed loop, and we make sure that we keep the patient and the family in the center of
Why
our
wouldn't anybody
thoughts.
want this? Why wouldn't everybody want this? Roberta wants this now. It's
I
20
know.
years,
It's
yeah.
funny.
Why wouldn't everybody say, "Wow, man, I'm going there. They got palliative care." That might be a come on to why I pick whoever I were to go get my cancer.
Yeah, I think
treatment.
everyone should get palliative care if they qualify for it. You have to have a diagnosis of a serious illness. It doesn't have to be terminal, but a serious illness. And then again, palliative care teams, you might meet them as few as like once every 6 months or once a year. If your disease is early in its stages and you don't really have too many symptoms, your family's doing fine, everyone's not very stressed, and then whenever things get rough, they can step in and you might see them every week for a while. So I think it's a great resource for everyone to get as part of their care team early
I
on.
say it's like Ghostbusters. Who else are you going to call? You got to go call Ghostbusters. Who else knows how to do it? Your doctor has 5-10 minutes with you. There's a limited amount of
Yeah.
palliative information or care they're going to give you in 5 or 10 minutes. They'll diagnose the problem and they'll give you a procedure, a pill, or a path to follow, but they don't have much time to spend holding your hand, answering your questions.
Yeah.
I had a question that just came in, and I really want to see if we
Yeah,
can answer it. Is
please.
what if you want palliative care, but your doctor feels it's not necessary?
Oh,
That is a great question, and I do feel that as the patient, if you feel that you qualify for palliative care services, I would strongly encourage you to, tell your doctor why you think you should have palliative care on board with you as part of your care team. You can always, I believe you can probably self-refer to outside agencies. So they might just look up outpatient palliative care, just Google outpatient palliative care in your local area, and you might see agencies that might not be connected to where.
but who would pay for that? Would you have to pay for that then?
No,
too,
it would still be covered by your insurance.
right? Okay.
I can't imagine a doctor saying that to
Yeah.
you, though, but apparently maybe so.
Well, because maybe it's a limited resource in that network. We only have so many seats, and we
Yeah.
give them to the people with the worst need, the most need.
Yeah, it could be a limited resource, could be that the doctor is also misinformed on what palliative care is, and
Could you change doctors?
that's
You don't want to advocate that, but,
Yeah.
but
Well,
that's, you've talked about that.
Yeah,
Roberta.
something we always do suggest if there is an issue, get a second opinion, a third
Yes,
opinion,
yes.
whatever it is. It doesn't mean you necessarily have to change a doctor at that point, but get somebody else's, get
Yeah.
another opinion and see where it goes from there.
I think it's so important to
Yeah.
get second and third opinions.
Yeah, or we've said
Or-
fourth or whatever it takes, right?
Yeah.
Until you feel comfortable that you're
Yeah.
getting the answer that
Yeah.
satisfies you. Yeah.
Have a team that you trust. I think that is the most important thing.
I think that's the biggest, and maybe, and I can only know my nurses listening, I better give them a plug, is maybe I don't get the traditional palliative care, but my team takes really good care of me, so maybe that's palliative care,
Yeah.
just different.
Right.
You know, like I said, when I'm down and sick and whatever going on, they're bringing me food and they're taking care of me and making sure I get my appointments taken care of, so maybe it's a different, not the traditional.
Yeah.
So I want to give them a shout out,
Yeah.
because I don't want to get in trouble when I go in to my TLC, my Tender Loving Care team, who
That's
really
exactly
takes
what
great.
palliative care is, the TLC team.
Yeah, they take great care of me, so I want to give them that shout out before I see them later. So. And like I said, it's just so much more I really wanted to talk about. We'll have to have you come back
Yeah,
because
we're out
there's
of
so
time.
much, and also
Well, because the engineer wouldn't shut up.
no, the questions are great. That's not where they're coming from. The fact that the questions are out there and they need to be answered, and I really
It's something nobody knows about.
Yeah.
We did not. Was this primary caregiver for my late mother, my late father, and my late aunt, who had no children. My mother's sister. I went through this 3 times. That end of life journey, Not once did anybody ever say, why don't you check out palliative? Hospice was brought up, and in some cases they went into hospice. But palliative was never, you went from, we're fighting all we got, and we're fighting to get in to see the doctor and get the doctor's attention and get more procedures and get more things. It was a fight, to we quit. And now let's just take care of it. There was never a transitional phase. There was never a support phase. There was never an additional phase that was offered.
Oh, I don't know if I can ask this real quick. Maybe I can because it's
go
my
ahead.
show, right?
Go.
The transition between palliative care and hospice.
What's the question?
Oh, I'm sorry. What is it? Is there a transitional period? I mean, if you're doing palliative care and
You
then it's
start
to the
one
point
and-
that is no longer working and you're getting worse, then how does that
You
go
quit,
over
you
to
quit
the
one
hospice?
and you sign up the next day and start the next?
Yeah. I mean, at any point when your primary doctor says, you know what, we don't really have any options for cancer treatment, or if the patient decides, I don't want to do cancer treatment anymore, and you have less than 6 months prognosis, then at that point, you can definitely go on to hospice. That being said, I do have patients that I follow for palliative care who are not getting cancer treatments, but they don't necessarily want to enroll in hospice yet because that word is scary. So I just see them, in my clinic once a month, help them with their pain management and symptom management. But they're not getting active treatment and they're not on hospice. So I just see them sort of, for some TLC.
Well, good, because everybody can need a little TLC. But I want to thank you very much for coming down. And really, like I said, there's hundreds of more questions. And also, I wanted to be able to talk to you at some point about some pain management. So maybe we can just come back and do an episode on that.
Yeah,
So-
absolutely. I would love to. Thank you so much for having me.
Well, thank you. I really appreciate it. Again, you're coming down. As long as you speak my name, I shall live forever is dedicated today to Julie Lynn. She was a longtime survivor from Oklahoma, a good friend to me, and just one of those survivors that you could really talk to. Sometimes it's hard to open your heart up to another survivor because you want to be able to give them hope and inspiration. But there's sometimes somebody we need to talk to and be able to really spill our guts to. And Julie was one of those, and I miss her dearly, and just want to dedicate today's show to her. So thank you.
Well, there you have it. One more reason, a good reason, to tune in each and every time. There's the kind of information. We all have these questions and we don't know who to ask. So tune in and we'll ask them for you, or join the conversation and tweet in. If you need help, we're here to help. And if you need immediate help, there's lots of resources. Today we'll plug one we've plugged a lot. How about the Hirschberg Foundation up at UCLA? All the good work that they're doing. And I believe it's pancreatic.org. Pancreatic.org. There we go. Pretty simple. Too simple. So if you need help, start there. And if you need more help, tune in each and every time to this show as we provide the real life stories and real life resources. People really going through this journey together. Living Hope on the Orange County Talk Radio Network, streaming live from our studios here. Thank you so much.